It begins in the emergency department at 3:14 in the morning. A 24-year-old woman sits upright on the gurney, her eyes wide, fixed not on the doctors but somewhere just above their shoulders, as if she's watching something move in the air that the rest of us cannot see. And then she speaks, not in the fragmented ramblings of the intoxicated or the disorganized chatter of the psychotic. No, she recites Shakespeare, Macbeth, but backwards, word by word, line by line. It pours out of her mouth like a corrupted recording, reversed audio from a play every English major knows by heart. Only here it's mangled, inverted, guttural. One of the nurses, jotting it down in the chart, writes, "Patient reciting Shakespeare backwards. Intelligible, coherent cadence. Not random." Another note, claims she hears voices inside her blood. The psychiatric resident on call, fresh-faced and exhausted, mutters the obvious. Psychosis, hallucinations, maybe schizophrenia unmasked by stress or drugs. But the patient's boyfriend, slumped in the waiting room chair, swears she's never touched anything stronger than wine and aspirin. No psychiatric history, no warning. Yesterday she was fine. Now she's quoting literature like a demonic radio station. The attending physician isn't impressed. Psychosis can start in a day, he says, already writing the orders for a toxicology screen and psychiatric consult. He shrugs. Could be LSD, could be schizophrenia, could be she's just creative. But then the patient jerks her arm in a way that doesn't belong to psychosis. A sudden, unnatural spasm that sends her wrist twisting and her head snapping sideways as though some invisible puppeteer yanked the strings. The monitors beep. Her pupils constrict. She mutters a line of poetry again. Fractured this time, broken mid-sentence. Hospital chart, 3:31 a.m. Patient displaying abnormal posturing. Possible seizure activity, e.g. recommended. This is where medicine and horror intersect, because anyone who's ever worked a night shift knows. Psychosis is messy, but it has a rhythm. Drug intoxication is chaotic, but predictable. What this young woman is doing, whispering in cadences that aren't her own, eyes rolling back, body half stuck in a posture like she's caught between movements. This is uncanny. Not possession, not madness, something worse, something you can't name yet. The intern mutters to herself. It's like she's stuck between being awake and dreaming. The neurologist hasn't been called yet, because right now psychiatry still owns the case. False leads begin stacking up like a bad hand of cards. Psychiatry, schizophrenia, schizoaffective disorder, acute manic episode with psychotic features, except schizophrenia doesn't usually show up like a Shakespeare recital. Toxicology, LSD, PCP, methamphetamine, nothing in her system. The tox screen comes back clean. Trauma, head injury, fall, the CT scan is negative. No bleed, no mess, and the quiet whisper in the back of everyone's head. Possession. Not the medical staff, of course. They don't say it out loud. But the boyfriend, clutching his phone, has already Googled, speaking in tongues sudden change demon. Doctor's note, for 12 a.m., patient attempted to climb off bed, repeatedly states, "They are in my blood. They are in my blood." Episodes of bizarre speech occasionally echolalic, displays dystonic posturing, vitals stable, for now. The ER team is happy to hand her off. Psychiatry evaluates. Their note reads, unclear etiology. Consider first break psychosis versus delirium of unknown origin. Neurology consult pending. It's the neurologist, older, impatient, who first says the words no one else is considered. This doesn't look like psychosis. This looks like her brain's on fire. The phrase sounds metaphorical, but it isn't. Because sometimes the immune system, your body's own soldiers, built to kill invaders, decides to misfire. And when it misfires in the brain, it doesn't just cause a rash or a fever. It rewrites reality. But no one knows that yet. Not tonight. By 5 a.m., the woman seizes. It starts subtle, her lips twitching, eyes darting like REM sleep, but then it erupts into a full convulsion. Her entire body stiffens, her back arches, The heart monitor spikes. Nurses rush in, giving Ativan, holding her down so she doesn't bite her tongue. The seizure lasts 2 minutes, then 3, then it stops, leaving her drenched in sweat, her breath rattling, her gaze unfocused. Hospital record, 5:07 a.m. Generalized tonic-clonic seizure. Postictal confusion. Patient minimally responsive. Neuro to admit. ICU recommended if recurrence. The boyfriend is crying. The doctors are arguing. Psychiatry still wants to label it psychiatric. Neurology insists on infectious or autoimmune. Infectious disease is paged. They want a lumbar puncture. And through it all, the young woman begins whispering again, voice hoarse but steady. This time not Shakespeare, something else. Fragments of poetry no one can place. But when slowed down, recorded, and transcribed later, the lines almost sound like they make sense. Like her brain is trying to communicate through static. Blood is chorus. Blood is choir. They are singing in the wires. She laughs at nothing, then falls silent. This is how autoimmune encephalitis begins. Not as a diagnosis, but as a haunting. And yet, to the untrained eye, to the overworked staff, it looks like madness. The neurologist orders an EEG. The spikes confirm seizure activity. They add Keppra to calm her brain. But the pattern doesn't stop. She keeps seizing in whispers, in half movements, in eerie, uncanny gestures that make the interns avoid looking her in the eyes. One nurse writes in the margin of the chart, "Patient stares through me like she's listening to someone else speak, pupils dilated, body jerks unpredictably. It's not demons. It's not drugs. It's her own immune system launching a war inside her skull. But no one has the proof yet. And if they don't find it soon, she's going to die." The ICU smells like antiseptic and electricity. Machines hum in the background, tracing every heartbeat, every spike of oxygen, every sudden drop. The young woman, her name is Emily, is now strapped to the bed with padded restraints. Not because she's violent, but because her body has become unpredictable. 1 second she lies still, eyes unfocused. The next she thrashes in movements that look choreographed, deliberate, almost balletic in their wrongness. Her arms flex at odd angles. Her back twists. Her lips form half-words that make the staff uneasy. House would have said it immediately. That's not psychosis. That's neurology doing bad interpretive dance. But here, in this hospital, no one is cracking jokes. The chart is filling with contradictions. Psychiatry note, 9:15 a.m., patient unresponsive to direct questioning. Alternates between mutism and echolalia. Impression. Possible catatonia. Differential includes schizophrenia versus severe bipolar with psychotic features. Recommend trial of antipsychotics. Neurology note, 9:16 a.m., patient displays orofacial dyskinesias, limb dystonia, autonomic instability, concern for underlying encephalitis. Antipsychotics may worsen condition. Strongly advise against until organic cause excluded. This is the battle of medicine. Psychiatrists calling it madness, neurologists calling it fire. Her boyfriend sits in the corner, a paper cup of cold coffee untouched in his hands. He keeps repeating the same line. She was fine yesterday. She was fine. But yesterday doesn't matter anymore. The seizures come in clusters now. Sometimes subtle, like her eyes flicking side to side in a rhythm that has no music. Sometimes violent, her body thrashing until 2 nurses and an orderly can barely hold her down. After each one, she whispers again. Sometimes it's poetry. Sometimes it's nonsense. But once, at 10:02 a.m., she looks straight at the camera in the corner of the ICU room and says, "They put microphones in my blood." The nurse writes it down. Later, when the team reviews the notes, no one can explain how she said it so calmly, as though it were fact. Tests begin piling up like bricks on a drowning patient. MRI, normal. CT, clean. EG, abnormal, yes, but nonspecific. Spinal tap, pending. The infectious disease team starts broad-spectrum antivirals, in case it's herpes encephalitis. That would explain some of it. Fever, seizures, psychosis, but she doesn't have a fever. And her spinal fluid looks almost normal. The problem with medicine is that the rare things masquerade as the common ones. A case like this is a wolf in a psychiatric costume. By noon, the debate turns ugly. Psychiatry pushes for haloperidol, an antipsychotic, to calm her down. Neurology pushes back. Give her that and you'll kill her. The ICU attending, caught in the middle, demands more data. Doctor's note, 12:17 p.m. Patient febrile to 38.2 degrees Celsius. Heart rate 132. BP 92/50. Concern for autonomic instability. Monitor closely. Risk of cardiac arrest. Autonomic instability. The kind of phrase that doesn't scare patients because they don't understand it. But it terrifies doctors. It means the automatic systems, the ones that keep your heart beating, your lungs breathing, your blood pressure steady, are breaking down. And you can't talk your way out of that. By 2 p.m., Emily is barely recognizable. Her hair is matted to her forehead with sweat. Her body jerks in sudden, violent motions, then collapses into eerie stillness. Her eyes open but don't track. She mumbles fragments of Shakespeare again. Out, out, brief candle. But backwards, slurred, as if her tongue has forgotten the direction of speech. The medical team huddles outside her room. The neurologist slams a chart shut. This isn't drugs. This isn't schizophrenia. This is her immune system tearing her apart. Order the antibody panel. Ndar, Amper, LGI-1, Casper-2. Every one of them. The resident looks up, confused. But those take weeks to come back. The neurologist glares. If we wait for the labs, she'll be dead by then. Start steroids. Start IVIG. Treat empirically. Empirically. A fancy way of saying we don't have proof, but we know. In the ICU room, Emily seizes again. Her body stiffens, jaw clenches, and a low moan escapes her throat. Half human, half something else. The nurse holds her hand, whispering, "It's okay, you're safe." But the monitors disagree. Heart rate 150. Blood pressure plummeting. Oxygen saturations dropping. House would have cracked a line here. Safe? She's about as safe as a snowman in July. But no one's laughing. The ICU alarm screams. Doctors rush in. Epinephrine. Fluids. Oxygen. Her body jerks once, then goes limp. For a moment, the room stills, everyone waiting to see if she's coming back. She does. Barely. Hospital record, 14:39 p.m. Code Blue called. Patient resuscitated after hypotensive episode. Transferred to ventilator support. High suspicion for autoimmune encephalitis. Treatment initiated. For methylprednisolone. IVIG. Her boyfriend signs the consent forms with shaking hands. He doesn't understand the words IVIG, immunotherapy, NMDA antibodies, but he understands the stakes. Later, in the conference room, the team reviews everything. EG spikes, psychiatric notes, infectious workups, the haunting poetry. The neurologist leans back, exhausted. This is anti-NMDA receptor encephalitis until proven otherwise. I don't care if the labs aren't back. The psychiatry resident mutters. So the immune system is causing her to act possessed? The neurologist smirks, bitter. Possessed is cheaper. But yeah, her body is attacking her brain. It's breaking the receptors that make her thoughts line up. Her speech flow, her movements make sense. To her, it feels like demons. To us, it looks like madness. To the immune system, it's Tuesday. And that's when it finally clicks for the team. This isn't just a psychiatric mystery. It's a war zone happening inside the skull of a 24-year-old woman who, 24 hours ago, was perfectly fine. Now, her brain is on fire. And the fire doesn't care whether you believe in demons or not. The ventilator breathes for her now. A steady mechanical hiss in and out like a metronome that doesn't care who lives or dies. Emily's chest rises and falls, but her eyes remain half open, fixed on the ceiling as if the fluorescent lights are trying to tell her something. The ICU at night is a strange place. Nurses whisper, monitors beep, and families drift in and out like ghosts. But Emily's room carries something heavier. Anyone who walks in comes out unsettled, as if they've stood too close to something uncanny. One nurse reports during handover, patient whispered full sentences while intubated. Tube in place, but vocal cords vibrating. Words unclear. Sounded like reverse speech. Another note. Repeated phrase. The choir is burning. The residents review the chart with a kind of unease they usually reserve for horror movies, not medical records. But every word is true. Someone heard it. Someone wrote it down. The neurologist walks in the next morning, sarcasm sharp as ever. Great. We've got a Shakespearean ghost on a ventilator. Anyone still think this is psychiatric? Psychiatry doesn't answer. They've backed off quietly after seeing the seizures, the dystonia, the blood pressure collapses. Madness doesn't drop oxygen saturations to 78%. The labs begin trickling back. Nothing conclusive yet. Autoimmune panels take time. Weeks sometimes. But the team can't wait. They've already hit her with steroids and IVIG immune treatments meant to reset the body's overzealous soldiers. And yet, Emily keeps slipping. Her autonomic system swings like a pendulum. One moment her blood pressure skyrockets, another it plummets. Her heart rate leaps from 60 to 160 without reason. Sweat pours off her body even as her skin feels ice cold. Doctor's note, 3:47 a.m. Patient displays signs of autonomic storm, tachycardia, hypertension, diaphoresis alternating with bradycardia and hypotension, requires vasopressors. Autonomic storm. The phrase alone makes doctors uneasy. It means the nervous system's control panel, the wiring that should quietly keep everything balanced, has gone haywire. The boyfriend asks questions the doctors can't answer. Why her? She's healthy. She runs. She doesn't smoke. She doesn't even drink coffee. Why her? The neurologist shrugs, weary. Because her immune system got bored. Because her body decided she was the enemy. Because life's unfair. It's the kind of honesty House would have respected. By day 4, Emily has slipped into something close to catatonia. She no longer fights restraints because her body barely responds. Nurses turn her every few hours to prevent bed sores, but her limbs fall like dead weight. And yet, sometimes her face twitches into a smile. Not a warm smile, not recognition. A smile too wide, too sudden, like her brain has confused joy with electricity. The residents exchange glances. One finally mutters, "It looks like she's smiling at nothing." The neurologist cuts him off. It's not nothing. It's antibodies. It's her immune system scrambling NMDA receptors. It's biology, not ghosts. But even he avoids her gaze when she suddenly opens her eyes mid-round and whispers, through the ventilator tube, "We are rehearsing in the blood." Medical chart, nurse's addendum. Patient continues to vocalize through intubation. Unsettling. Staff report feeling watched. The hospital is supposed to be clinical, sterile, detached. But Emily's case blurs the line. She doesn't just look sick. She radiates something uncanny. Tests continue. PET scans. More spinal fluid analysis. Blood work. Everything pointing in circles. Nothing definitive. Until the CSF comes back. Lab result. 5th day. Positive for anti-NMDA receptor antibodies. There it is. Proof. The neurologist slams the paper down on the table like a winning card. Finally, she's not crazy. She's inflamed. The psychiatry resident mutters. So she's not psychotic. Her brain's being attacked. The neurologist nods. Exactly. The immune system is binding to her NMDA receptors, glutamate receptors in the brain. Those handle memory, thought, speech. Knock them out and you get seizures, psychosis, catatonia, autonomic storms. Basically, she looks possessed, but it's biology. The team exhales. At least now they can name the monster. But naming it doesn't tame it. Treatment ramps up. High-dose steroids. Plasma exchange, literally filtering her blood to remove the antibodies. IVIG continued. Her body, however, doesn't cooperate. Each day brings new crises. Fevers spike, then vanish. Seizures erupt despite medication. At one point, she begins thrashing so violently that the ventilator tubing nearly dislodges. Alarms blaring as 3 staff rush in to hold her down. House would have smirked. She's not going to make this easy. Nothing worth diagnosing ever is. But the reality is grim. Autoimmune encephalitis kills if untreated. Even with treatment, survival isn't guaranteed. Some patients recover completely. Others live with permanent neurological scars. Some never wake up. And Emily hovers in that liminal state. Between coma and life. Between science and the uncanny. The pseudo-documentary voice of the hospital charts continues. Nurse's log, day 6, patient-mouthed words around tube. Lip reading suggests, I am rehearsal, unable to confirm. ICU attending, day 6, autonomic instability persists. Temperature fluctuates 35 to 39 degrees Celsius, requiring sedation for agitation. Prognosis guarded. Neurology progress note, day 6, diagnosis confirmed. Anti-NMDA receptor encephalitis. Continue immunotherapy. Poor prognostic indicators. Autonomic storm, refractory seizures. Family counseled. The boyfriend listens, nods, and finally asks the question no one wants to answer. Is she going to survive? Silence. Because no one knows. Day 7. The ICU hums with the same rhythm. Monitors beeping, ventilators sighing. Infusion pumps ticking like clocks that don't keep time. But around Emily's room, the rhythm feels wrong. Too many alarms. Too many staff hovering. Too many eyes glancing at her chart with the expression everyone tries to hide. Doubt. She lies motionless most of the day now, except when she doesn't. At 3:02 a.m., she suddenly arches her back, muscles rigid as steel, eyes snapping wide. Her mouth opens as though she's about to scream, but no sound comes out. Only the hiss of the ventilator. The monitor spikes into chaos. Heart rate 160. Blood pressure 200 over 120. Nurses rush in, pushing sedatives, pressing her shoulders down so she doesn't dislocate something. And just as suddenly as it began, it stops. Her body collapses, drenched in sweat, limp as a discarded puppet. The resident writes in the chart, another autonomic storm, brief, severe, required 4 midazolam. Patient appears postictal. Another resident mutters under her breath. It's like her brain is short-circuiting in waves. The neurologist snaps. That's exactly what's happening. Stop romanticizing it. But there's nothing romantic about this. The team meets again. Steroids, IVIG, plasma exchange. They've thrown the textbook at her. And still, Emily hovers at the edge of catastrophe. Maybe it's too late, one resident suggests quietly. The neurologist slams a hand down on the table. No, not too late. These cases take weeks to turn around. If we give up now, she's gone. If we push, maybe she comes back. House would have enjoyed the drama. He'd probably say something like, it's not a medical mystery without a few dramatic resuscitations. Otherwise, it's just neurology doing paperwork. But here, it's not a punchline. It's a wager. The boyfriend hasn't left. His clothes are wrinkled, his face hollowed by exhaustion. He sits by her bedside every hour they'll allow, reading aloud from the same battered paperback book she used to keep on her nightstand. He reads poems, as if by adding enough words to the room, he can drown out the voices in her blood. One nurse notes in the chart, family present, reading poetry to patient. Patient's eyes open briefly. No tracking. It's a small thing, but the team notices. On day 10, something shifts. Not much, not enough, but something. During rounds, as the team murmurs over her chart, Emily suddenly lifts her hand. Just a few inches, trembling, before it drops again. Everyone freezes. Voluntary? One resident whispers. The neurologist squints. Maybe, or just a spasm. But then it happens again hours later. This time her fingers curl, grasping weakly at the air. And then, at 11:14 p.m., while the boyfriend is reading aloud, her eyes flicker. Not random darting, not seizure activity. Tracking. She looks at him, only for a second, but long enough. He gasps, drops the book, and shouts for the nurse. The nurse writes, patient appeared to make eye contact with family. Possible purposeful movement. The note is cautious, but the staff feel it too. A glimmer, a flicker of something breaking through the fog. Still, the storms continue. Autonomic chaos keeps her tethered to vasopressors and sedation. Her blood pressure rises and crashes. Her heart stutters in rhythms that make cardiologists nervous. But every so often, in the middle of all that chaos, she moves again. A hand, a flicker of the eyes, a faint sound around the tube that almost resembles her name. The boyfriend clings to each one like lifelines. "She's still in there," he whispers. "I know she is." The team is careful not to promise anything, but privately they admit patients who respond even faintly this early. Sometimes they make it. House would have rolled his eyes at the sentimentality. Sometimes they make it, sometimes they don't. Flip a coin. At least with a coin toss, you've got odds. But even House would have noticed what's happening here. The treatment is working. Slowly, painfully, but working. By day 12, the seizures begin to ease. Still present, but less frequent. Her vitals, while unstable, show longer stretches of relative calm. And when the nurses suction her airway, she mouths something again. Takes 2 staff to confirm it, lip-reading carefully. She mouths, "Help me." The note in the chart is brief. Patient-mouthed words around tube, interpreted as, "Help me." The ICU attending stares at the note for a long time, then circles it with his pen. Proof she's coming back. But the recovery of autoimmune encephalitis is never cinematic. It's not a sudden awakening. It's not an exorcism where the demon vanishes in smoke. It's slow, uneven, terrifying. One day she opens her eyes and follows a command. The next she seizes for 30 minutes straight. One day she mouths her name. The next she's mute again, staring through everyone as if she's gone. The staff begin to whisper. It feels like she's haunting herself. Still, the antibody titers confirm what they already know. Anti-NMDA receptor encephalitis. Her immune system is at war with her brain. But the treatments are pushing back, molecule by molecule, until there's enough receptor function left to let her peek through the madness. By day 15, the ventilator is turned down. She breathes a little on her own. Weak, shallow breaths, but hers. The tube remains in place, but the team starts discussing extubation. The boyfriend weeps when they tell him, "So she's going to be okay?" The neurologist pauses. "She's alive. She's fighting. That's all we know." House would have said, "Congratulations. She's alive for now. That's the best medicine ever promises." And he wouldn't be wrong. But in the ICU, surrounded by machines, alarms, and fear, the fact that Emily can breathe, even for a moment, feels like a miracle. Day 21. The ventilator comes out. It's a tentative moment heavy with risk. The respiratory therapist stands ready, suction catheter in hand, while 2 nurses steady her arms. The attending gives the nod. The tube slides out in one smooth motion, and Emily coughs, gasps, and then, finally, breathes on her own. Her voice is a rasp, her throat raw from weeks of plastic and forced air. But she whispers something. Not Shakespeare, not backwards poetry. She whispers, "Water." The boyfriend bursts into tears. The nurses smile for the first time in weeks. The neurologist, arms crossed, mutters, "Well, at least she's not asking for Hamlet this time." Recovery doesn't come like lightning. It comes like dawn. Slow, uneven, with shadows still clinging. Emily drifts in and out of awareness. Sometimes she recognizes her boyfriend. Sometimes she stares through him. Sometimes she laughs at nothing. Sometimes she weeps without sound. The staff document everything. Nurses note, day 23, patient oriented to self only, recognized partner, asked what happened, short-term memory poor. Neurology progress note, day 25, patient able to follow simple commands, language fragmented, occasional neologisms, no seizures in 48 hours, autonomic instability improved, continuing IVIG. Each note feels like an artifact, a breadcrumb trail out of the labyrinth. And yet, the uncanny lingers. Even as she improves, fragments of the horror remain. One night, a nurse hears her murmuring in her sleep. "The choir in the blood is quiet now. It's written down. Reviewed on rounds. No one comments." House would have smirked. At least the choir's taking intermission. But everyone in that ICU remembers what it sounded like when she was possessed by her own immune system. They know how close she came to never waking at all. By week 5, Emily can sit up in bed. She drinks water. She eats applesauce with trembling hands. She speaks more clearly. Though her sentences trail off, her words sometimes stumble. She asks what happened, again and again, as if her memory resets every hour. The neurologist explains it each time. Your immune system attacked your brain, specifically your NMDA receptors. That's why you had seizures. That's why you couldn't speak. That's why it felt like you were going mad. She nods, then looks away, unsettled. I remember voices inside me, like music, but wrong. The room is quiet, because how do you tell a patient that their hallucinations weren't madness, but the chemical misfiring of their own synapses? How do you explain that their sense of being haunted was, in a way, true just not by spirits but by antibodies? Her boyfriend holds her hand. "You're safe now," he whispers. But the neurologist, ever the cynic, reminds the team later, "Safe is a stretch. Relapse rates exist. Some never recover fully. She might not. Medicine doesn't do guarantees." Still, improvement continues. Physical therapy, speech therapy, cognitive rehab. Emily stumbles through each session like a newborn learning the world again. She struggles to remember dates, but she recites poems perfectly, word for word. Not backwards this time. Discharge summary. 6 weeks later. 24-year-old female admitted with acute psychosis, seizures, and autonomic instability. Workup revealed anti-NMDA receptor encephalitis. Treated with steroids, IVIG, plasmapheresis. Prolonged ICU course requiring intubation. Gradual recovery with residual cognitive deficits. Prognosis: guarded but hopeful. Follow-up with neurology and psychiatry recommended. The summary reads sterile, clinical, but behind each line lies horror. Behind each word lies the weeks of chaos, the nights of storms, the sound of Shakespeare reversed through cracked lips. Emily leaves the hospital walking unsteadily, her boyfriend at her side. She doesn't remember much of the ICU. She doesn't remember the seizures, the storms, the way nurses whispered about feeling watched in her room. What she does remember are fragments. Faces leaning over her, flashes of light, the eerie certainty that something was inside her veins. She asks the neurologist, before discharge, "Was I crazy?" The neurologist shakes his head. "No, you were inflamed." House would have said it differently. Crazy is just inflammation with better PR. The truth is harsher. If her case had been written off as just psychosis, she'd be dead. If psychiatry had won the early argument and pumped her full of antipsychotics, she might have spiraled into malignant catatonia and never returned. If her boyfriend hadn't insisted she was different, if the neurologist hadn't pushed for antibodies, her story would have ended with an obituary, not rehab. And that's the haunting part, because for every Emily, there are others. Patients dismissed as mad, locked in psychiatric wards, their brains on fire while doctors argue over diagnoses. Some never get the chance she did. The documentary voice lingers here, a warning in the form of statistics. Anti-NMDA receptor encephalitis affects roughly 1 in 1.5 million people each year, often young women, often first mistaken for psychiatric disease. Mortality, untreated, over 50%. With treatment, survival climbs to 75%. The difference between life and death rests on suspicion, on the willingness to look beyond psychosis, on doctors who don't accept the easy answer. Emily returns home months later, still shaky, still struggling with memory, but alive. She keeps a journal now. Every day she writes what happened, so if the fog returns, she can read her own survival in her own hand. In one entry, weeks after discharge, she writes, "They said my brain was on fire, that the voices were not real, But I know what I heard. A choir in the blood. A chorus rehearsing. Maybe it was just neurons misfiring. But maybe the body keeps music even when the mind forgets. I survived. But part of me still wonders. What if the choir comes back? The page ends there. The camera of the pseudo-documentary I lingers on the journal. The words fading into silence. And the narrator's voice. Sharp, sarcastic, weary, but honest. Cuts in one last time. She wasn't possessed. She wasn't psychotic. She wasn't cursed. Her immune system decided to stage Macbeth inside her brain in reverse. And medicine almost missed it. The moral? Sometimes madness is just inflammation wearing a mask. And sometimes the scariest thing isn't demons. It's your own body turning on itself. The screen fades to black.